have no real disclosures. I kind of took the liberty to change the talk slightly to kind of narrow it on neurovascular disease, intracranial atherosclerotic disease, which is kind of my area of research, aneurysms and AVMs, and on the arterial side mostly. But as we transition in radiology, being a clinician from volume to value-based care, I think it's important as a radiologist to understand that we're developing and leveraging imaging, and that precision medicine will be what will be required for the future of this field. And traditionally radiology has been anatomically localization and identification of certain pathologies and pattern recognitions, but modern imaging and interventional applications will be the future, certainly histopathological or earlier diagnoses with high-res MR, molecular imaging, risk stratification to guide patient management and treatment, such as with quantitative, metabolic, or functional MR imaging, or novel modalities, new or non-invasive interventions such as MR-guided ultrasound and other modalities. Here at Northwestern, we have an excellent bioengineering department where we collaborate closely with the Department of Radiology, and with their physics expertise, we have tried to study novel applications for MR, MRA sequences in various neurovascular pathologies, my area of interest being intracranial atherosclerotic disease, but also working with Drs. Carroll and Merkel with hemodynamic failure, tissue perfusion, and intracranial atherosclerosis, or any type of really impaired cerebrovascular reserve, or understanding hemodynamic flow in various neurovascular pathologies, and also functional and anatomic assessments. For those who don't know, ischemic stroke, of course, is one of the largest problems facing the nation and the world. Intracranial atherosclerotic disease is relatively uncommon in the North American population, 7 to 10% of Caucasians, and about 15 to 30% of African Americans. But worldwide, it's probably the highest incidence. 30 to 50% of stroke is related to intracranial atherosclerotic disease, and shares all the common cerebrovascular and cardiovascular risk factors that we know of. Initially, the WASIT trial was a randomized controlled trial looking at atherosclerotic disease treatment with just aspirin versus anticoagulation therapy, and they learned from that those trials that the recurrent stroke risk in intracranial atherosclerosis was very high. It's 22% over 1 year, and that was in patients who had significant intracranial stenosis. So some assumptions, and naive assumptions, were made at that time that early intervention would be favorable and that the stroke mechanism would be due to just this luminal stenosis, and that was predicated on the carotid endarterectomy and stenting trials, suggesting that from NACIT and CREST, and eventually that the symptomatic 50 to 70% carotid stenosis is something that you should intervene upon. The thing is that with intracranial evaluations, we're dealing with 2-3 millimeter vessel diameters, and often, unfortunately, non-invasive imaging often fails compared to digital subtraction angiography, because with respect to MRA, you have inaccurate flow gaps, flow enhancement dependent, even with contrast enhanced MRA, or even CTA, the vessel diameter is so small that the resolution is just not enough. And here, so we jumped on that bandwagon as neurointerventionalists, and you see a significant severe stenosis here. Post-angioplasty, we see a dissection of the vessel, and then stenting, we feel very good that we've established blood flow and diameter to the vessel, but 6 months later, there's a recurrent stenosis. So that was very common. The randomized controlled trial on medical management interventions corroborated those findings, that certainly medical management was superior to any type of interventional therapy, and that the recurrent stroke risk still remains significantly high, even with this optimum aggressive medical management approaching 12% over 1 year. And so the question is, could MR imaging stratify this risk for patients for recurrent stroke, or understand the different mechanisms of stroke? And plaque disruption is one of the common methodologies for stroke, causing in situ thrombosis and perforator occlusions and ischemia. Additionally, that same mechanism with unstable atherosclerotic plaques can result in intraplaque hemorrhage, fibrous graft ruptures, causing artery thromboembolic complications, similar to the carotid talk that Dr. DeMarco showed. And then perhaps more commonly in intracranial atherosclerotic disease, it's this luminal stenosis, this flow limitation, hypoperfusion that occurs in the distal vascular territory that results in watershed or border zone ischemia, such as this ACA-MCA border zone infarction from a severe ICA stenosis and a basilar stenosis at the same time, causing an MCA-PCA watershed distribution of infarct. So, although the majority of ischemic complications are thromboembolic, such as in carotid atherosclerotic disease and probably even intracranial atherosclerotic disease, there is certainly a greater predisposition to flow or hypoperfusion-related ischemia, and that's something we can take advantage of from an MR imaging perspective to capitalize on and try to understand at least that mechanism, and actually both mechanisms with vessel wall imaging and high-resolution imaging. But that's beyond the talk for today. Smaller, these vessels have smaller diameters, fragile vessels, so the flow-limiting stenoses can really affect the distal vascular bed. There's less direct circle of Willis collaterals in an MCA stenosis than an ICA stenosis, so you're certainly dependent on PL collaterals and various comorbid conditions with tandem stenoses and other comorbidities that can affect outcomes. So the characterization of not just the stenosis, but the distal perfusion or flow across the stenosis is quite important to understand whether we're going to proceed with medical or interventional management. And certainly the study looked at a retrospective 142 intracranial lesions that underwent angioplasty and stenting, and when they stratified the patients and those people who had certainly hyperperfusion ischemic symptoms, either watershed DWI or perfusion imaging issues, those patients were shown to have significant favorable outcomes with intervention. So perhaps this is a sub-cohort that you'd be able to stratify. As opposed to using OEF or MR perfusion imaging, certainly the qualitative presence of PL collateral supply can indicate CVR impairment as well, and that's something that DSA and even 4D CTA modalities can take advantage of because they have such high spatial and temporal resolution, but they are invasive diagnostic studies with, of course, radiation. MR-MRA modalities have been relatively crude in this respect. People look for flare hyperintensity signals or trying to use time-resolved 4D MRA, and although for high-flow lesions like an AVM, it's certainly is acceptable, it has fairly poor resolution to unable to visualize the PL collaterals. These vessels are 1 millimeter, 0.5 millimeters. So ASL MRA has been promising. Here at Northwestern, Dr. Carroll's laboratory had studied this 2D projection MR DSA technique using a sliding window subtraction technique, using radial sampling for very fast speeds and achieving fairly high spatial resolution and significant frame per second temporal resolution. This could probably be even in diagnostic cerebral angiography, we use 3 frames per second. So this could certainly, we could compromise some of the temporal resolution for even greater spatial resolution here, but something to be aware of. Perhaps more recently, phase contrast MRA, quantitative MRA techniques have really become interesting in this field for assessing intracranial atherosclerotic disease. It's a non-contrast technique, as you know, excellent background suppression, and can actually quantitatively determine blood flow velocities. Of course, there is longer imaging times, and it's very operator dependent and time intensive with post-processing required. Some vendor-derived software has been developed for that, such as Nova, but from Vasol. But a retrospective study back in the 2005 and prior to that suggested that if you were able to characterize symptomatic intracranial atherosclerotic disease from a low to a normal distal flow status, you had an increased stroke risk. And just recently, within the last year, the Veritas trial certainly capitalized on these preliminary findings, and in a prospective multi-center study, they were able to demonstrate that if you had a symptomatic vertebrovascular stenosis that was severe, that in subgroup analysis, the low versus normal distal flow status was associated with significantly increased stroke risk, and that low flow states were associated with significant severe or tandem vertebrovascular stenoses. And this subpopulation is actually being now a candidate for an interventional trial, randomized trial, using these parameters. And another Myriad trial is using QMRA or PC-MRA for assessing anterior circulation stroke as well in the setting of intracranial atherosclerotic disease. We have studied a more relative, not yet quantitative technique, but for looking at flow in this disease status using 4D Flow MRI, which is 3-directional velocity encoding PC-MRA, and we've used it for all these 3 pathologies that I'll speak about, ICAD, aneurysms, and AVMs. But what we saw that in the 22 patients and 10 healthy normal subjects, we looked for flow asymmetries in a setting of IC-MCA or basilar stenoses. And what we saw is that certainly, as predicted, IC and MC stenoses would have ipsilateral decreased flow, relative flow, but with increased collateral flow to those distributions to augment and maintain cerebral perfusion, and whereas basilar stenoses had no asymmetry effects, of course, because it affects bilateral flow. And so we believe that this may be a nice relative flow technique for visualizing the impact of ICAD on local and global cerebral flow, and it can also demonstrate the impact of intracranial stenoses on distal flow and ipsilateral collateral hemodynamics. With respect to aneurysms, intracranial aneurysms, certainly unruptured intracranial aneurysms have a very high incidence, 2 to 3% of the general population, so probably 2-3 people in this room harbor an aneurysm. The majority of small aneurysms are very small, thankfully, and that certainly indicates a low risk of rupture, but the aneurysm rupture, when it occurs, has a very high morbidity and mortality, and that's why it is almost always followed with imaging. Various patient aneurysm-specific factors can determine that risk, and imaging, and these are predominantly imaging-dependent anatomic factors like aneurysm size, location, morphology, and perhaps even some novel imaging markers that can be studied, such as hemodynamics, wall pulsatility, and permeability. Imaging has been critical for not only assessing diagnostic risk and treatment planning, but really observations to see if aneurysms are progressing in those that are being followed or recurrences in people who have been treated with endovascular coil embolization. A lot of our patients, almost all of our patients, get MR angiography for that. Although DSA is the gold standard for treatment planning of intracranial aneurysms, it of course has an invasive risk, and hence we reserve it for those patients who are going to require treatment, or if there's a high suspicion of subarachnoid hemorrhage or a very small aneurysm in a patient who had a negative study, whether it be MRA or CTA. Non-invasive modalities are preferred for initial screening and serial follow-up. Time-of-flight MRA is typically preferred to contrast-enhanced MRA or CTA, and that's basically due to the streak and beam hardening artifact is much worse on CT than a metallic susceptibility artifact of platinum quills are on MR angiography. We try to avoid gadolinium because of all the new gadolinium retention risks, and of course avoiding radiation iodinated contrasts for CT techniques. But 3T has been shown in several studies to be superior to 1.5 Tesla MR, time-of-flight MRA imaging, higher inter-observer agreement, as well as negative predictive value compared to the gold standard DSA. Additionally, the recent paper suggested that the ability to scan on 3T, although previously people had thought that that would increase the susceptibility artifact, you were able to take advantage of the higher SNR and allow shorter TE. So the shorter your TE is, the less artifacts you produce. And in fact, when they compared 3T, 1.5T, and DSA on the diameter of the aneurysm remnants, they were able to see that 1.5 Tesla was fairly comparable to DSA, but 3 Tesla actually showed a larger remnant. So perhaps 3 Tesla may actually be higher sensitivity for DSA, and there's various reasons for that, and which I'll show you an example of. But when we compare time-of-flight MRA versus contrast-enhanced MRA, both are excellent. Pooled sensitivity specificity analysis showed that there was really no difference in comparing it in this meta-analysis, looking at these two techniques versus DSA. There's no statistical difference, and in fact, contrast-enhanced MRA may actually be prone to some venous contamination. There's some conflict in literature that larger aneurysm remnants may be superiorly evaluated with contrast-enhanced MRA because you have that short echo time and enhancement. But again, despite that, there was no difference in the classification of the remnants, so hence there's no difference in the treatment decision for the patient. This was a patient that I coiled, superior apophyseal left ICA aneurysm, which to me had very little, if any, neck remnant on follow-up imaging here. But the time-of-flight MRA, you could see that there is some filling into the coil mass. This is the contrast-enhanced MRA technique. It also demonstrates the same exact thing, but you see the venous contamination in the cavernous sinuses that can sometimes it can obscure the exact vessel or aneurysm delineation of the wall. Of course, when you have intracranial stents being utilized to treat these aneurysms, that increased metallic susceptibility plus minus a coil mass will require contrast, enhanced techniques, and that's due to this marked loss of signal void or loss of signal on the time of flight imaging. Additionally, when we're using just stents alone, like these new flow diverting stents, which have very tight braided meshes that can induce the aneurysm thrombosis without even coiling the aneurysm, that slow residual flow in an aneurysm may not be picked up with time of flight imaging. Conversely, if you see if there's thrombus in the aneurysm, you may not be able to pick it up on time of flight imaging, and vice versa. T1 shortening artifacts from that thrombus can obscure the evaluation after flow diverter stent placement. Some advantages have been shown with a time-resolved contrast-enhanced MRA technique in this subpopulation of patients versus contrast-enhanced MRA. And despite the interpolation and zero filling that they use, giving us trying to accommodate this less spatial resolution, it's still less. And but what it does is it does give you a dynamic scan, so you have less venous contamination, higher sensitivity to that slow residual inflow of an aneurysm, and in this time-resolved technique, you get a pre-contrast mass, so you can really get rid of some of those T1 shortening effects and minimize the artifacts from thrombus or aneurysm wall enhancement. This was a study that they performed, just published a few years ago, looking at these two techniques, and it's certainly surprising to me, because our time-resolved MRI does not look very appealing to me, but still they were able to show that the quality of the visualization of the reconstructed artery after placing these flow-diverting stents was better, as well as the luminal diameter closely approximated the DSA findings with a significant dropout on the time of flight MRA. This was the same exact patient that I showed you earlier that I coiled. She also had a contralateral, very large aneurysm that we decided to treat with flow-diverting stent. You can see 6 months later that the aneurysm is still filling through this single jet. There is contrastasis in here, but the aneurysm is patent still. We'll probably give her more time. But you can see these time of flight versus contrast-enhanced MRA techniques. There is a residual aneurysm, but on a time of flight, we weren't sure, is this T1 shortening? Could this be a thrombus? Without the DSA, you would be a little bit hesitant. And even on a contrast-enhanced MRA technique, fresh thrombus can enhance if there's a delay. So this was the technique that they described in using the time-resolved contrast-enhanced MRA. You can see the thrombus, what they thought was thrombus in the aneurysm, but actually on the DSA, it had reopened even more than initially seen with the pipeline, and that's because this pipeline stent had migrated away from the neck of the aneurysm, allowing this large aneurysm to reopen. With the time-resolved MRA technique, they certainly confirmed that recurrent aneurysm as the DSA shows. As you know, intracranial aneurysms are life-threatening lesions. They're anatomically and pathologically diverse, and the methods of risk stratification are still imperfect. They remain controversial. As we mentioned, the aneurysm-specific factors. There's, of course, patient-specific factors, but it's significantly incomplete assessment, and hence we often don't know if a small aneurysm that we're going to follow is going to rupture or not rupture. Altered hemodynamics certainly correlate with aneurysm development and vascular alterations. It's not, it's not surprising that aneurysms develop at bifurcations of vessels, and so whether it's aneurysm or AVM hemodynamics, could this be used as a new risk factor? There's been multiple studies on CFD analysis on intracranial aneurysms, but some criticisms of that, of course, is that these are presumed boundary conditions and rigid vessel wall modeling, variability of the calculated parameters, and 4D Flow MRI, we have utilized that for which may allow some more patient-specific conditions and some in vivo assessment of vessels and aneurysms. This is a 4D Flow MRI standard technique that we've used here, using post-processing of 3D path lines and wall shear stress analysis using MATLAB. This was a study on 19 patients. We stratified them on different aneurysm morphologies and sizes: large saccular, small saccular, large giant fusiform. You can see the path lines demonstrate various different flow patterns, and we were able to demonstrate that despite all three types of aneurysms being able to rupture or demonstrate progression, that there were the saccular aneurysms demonstrate higher peak velocities and wall shear stress compared to fusiform aneurysms, and that the vorticity and wall shear stress was significantly different in multisaccular large aneurysms. So we were able to at least correlate 40 flow MRI findings with size and morphology on aneurysm hemodynamics, and this may be something that can be utilized with further research. When we talk about AVM diagnostics, the AVM rupture is also a very important etiology for hemorrhagic stroke, like intracranial aneurysms. It's a rare pathology, lower incidence than aneurysms, but still significant morbidity and mortality. The rupture risk annually is quite variable. It can range from 1 to 33%, and that's because it's dependent on the presentation of the patient, the accumulation of risk over a younger patient's age versus an older patient, and then of course the inherent anatomic risk factors, the deep location of an AVM, deep venous drainage, any associated aneurysms or venous stenoses, and even hemodynamics. People have, even with digital subtraction angiography, that people have suggested that those patients who have long draining veins or slow transit times across the AVM nidus, that may suggest increased resistance and predisposition to rupture. So the imaging is, of course, very important for the diagnosis and angiographic characterization of AVMs, the Spetzel-Martin grading, which is correlated with surgical risk, as well as the anatomic rupture risk assessment with these various factors. Now, although non-invasive CT-MRA and dynamic techniques have improved, DSA still is required for treatment planning in these lesions. It remains the gold standard because it has the highest spatial and temporal resolution, clearly delineates the arterial and venous phases, the contribution of arterial distributions for embolization planning, and the identification of subtle pathologies like intranidal and venous aneurysms. Time-of-flight MRA is excellent in the diagnostic component because it has very high spatial resolution, and that's because high-flow AVMs, unlike atherosclerotic disease, have very robust flow enhancement. They're high-flow lesions. Gadolinium is rarely required, but the main limitation, of course, is the dynamic information. And for that, people have used various time-resolved contrast-enhanced MRA techniques. I think here I described a 4D radial approach to getting a 3D radial MRA technique to understand these high-flow lesions to give it some temporal resolution, but also techniques from the University of Wisconsin, like the 4D radial PC-MRA technique, also enables velocity encoding, and in their small study they were able to show that increased wall shear stress that they were able to calculate from their patients was associated with symptomatic presentations. Again, we've used 4D flow MRI here to study our AVM populations. You can see various AVMs here with different flow patterns, and we're able to see that there was a heterogeneous flow independent of the grade of the AVM, so that this arterial and venous variability was very AVM specific. There were 4 patients who we actually serially scanned during embolizations, and the PC-MRA component was able to develop this flow connectivity mapping, able to understand which arterial feeder was supplying which component of the AVM, and then also on serial embolizations, you could see that there was interval compaction of the AVM and redistribution of velocities during each stage of the embolization. So 4D flow MRI may have potential to actually monitor and guide embolization treatment planning. You may choose the highest flow feeder because that may induce the lowest risk post embolization, which is often staged, and you can often have reperfusion hemorrhage complications if you leave a small nidus with a large feeder left in the patient. In conclusion, multiple standard and developing MRA modalities are valuable in the assessment of neurovascular disease, and certainly are approaching the spatial and temporal resolution of DSA, such as the techniques that we've just kind of gone over through today, and PC-MRA and quantitative MRA techniques, as well as 4D flow MRA, allows the quantitative and qualitative hemodynamic analysis of aneurysms and AVMs, but also local flow analysis and relative impact on collateral global flow in intracranial atherosclerotic disease, and I think that's why those applications are transitioning to clinical trials. Yeah. Thank you.